Let's wait just a couple of minutes to see the participants to log in, enter the floor. All right, good afternoon, buenas tardes. Welcome to our episode number 13 of Pandemia, a series of webinars that bring information about COVID-19 and COVID-19 vaccines with a focus on the Latino community. This is a collaboration between the Latino Commission on AIDS and the COVID-19 Prevention Network. My name is Luis Mares. I am the Director of Community Mobilization Programs at the Latino Commission on AIDS in New York City. And today I'll be your host and your moderator for this webinar. Pandemia has been bringing information, updated information since July 2020, approximately, from the time when the pandemic just started and trials were rolling, and we're trying to enroll participants, Latino participants in the studies. We went through the process of approval of vaccines through all the rollout process of vaccines as well, and the periods of new strains, and increased sensitivity to additional doses and boosters. To this day, the epidemic is partially controlled with not just the vaccines, but also preventive measures, the masking that we have used. And with this, we have been able to decrease the mortality of COVID-19. And also some measures have been released, like no everybody uses masks today. Today, our webinar will focus on the booster doses of COVID-19. Who needs them, why it's important, the different combinations possible depending on what vaccine we took at the beginning, and some little information about what vaccines have been used in other countries in Latin America, and also how this can impact or determine what booster that people may use. For this today, we have our friend, she's already been with us before, Dr. Julie Davidson, who is a community-based infectious disease physician and health equity researcher. She's an assistant professor of medicine at Harvard Medical School and is co-director of the community research program at Massachusetts General Hospital Chelsea Healthcare Center. She received her MD from Harvard Medical School, completed an internal medicine and primary care residency at Brigham and Women's Hospital, and infectious disease fellowship in the Massachusetts General Hospital, Brigham and Women's Hospital program. Dr. Davidson runs a National Institute of Health funded research program in the Massachusetts General Hospital Division of General Internal Medicine and Morgan Institute focused on understanding and addressing disparities in outcomes for infectious diseases with attention HIV and AIDS and Zika infections. Dr. Davidson was a recipient of the Planeta Powerbank Award, who is awarded to top 100 individuals for Latinos in Massachusetts, and the Harvard Medical School Arnold P. Gold Foundation Humanism in Medicine Award. She's a member of the Latinx expert panel for the National Institute of Allergy and Infectious Diseases COVID-19 Vaccine Prevention Network. Please write your questions for Dr. Davidson for the end of the presentation in the Q&A box. So thank you again for being with us. Good afternoon, and we have Dr. Davidson now on the floor. Julie, you can go ahead.
Thank you so much, Luis. And if I could share my screen. Wonderful. Can you see this okay?
Yes.
Super. Well, muchísimas gracias. Buenas tardes. I'm so happy to be back with my friends here. I was last with you in December, and while some things are different, we know that many things are the same about how we prevent COVID. And so one of our commitments in doing these talks is to promise to give to you the information that we know in terms of the science in the moment, the areas that are we're still unsure about. And one of the things that we've all, I think, learned in this process of the pandemic is an openness to change, and what we might know now may change in the future. And that's why myself, as well as Luis and our colleagues, are committed to coming back again and again to inform the community about what we know. I thought I would begin with a brief review on SARS-CoV-2, the virus that causes the disease COVID-19, update us about where we are in terms of the pandemic and the current variants, and then spend most of the time talking about vaccination and the next steps, really focusing on health equity and what we've learned from working with HIV populations around how we can remain committed to health equity and improving access to COVID-19 prevention and treatment measures. And then really look forward to your questions. So we know now, more than 2 years into the pandemic, that this virus that causes COVID-19 is spread predominantly through respiratory transmission. And most often this transmission occurs through droplets that's expelled from the airways when we do simple things like cough or sneeze or sing. And so a lot of this transmission occurs within a close distance of 6 feet. But these droplets, these moisture particles that come out of the airways and have virus inside, can go quite far. And that was a really important discovery early on in the pandemic, was the recognition, particularly as we get louder in our talking, when we're singing, for example, in a religious setting, when we're in choir, when we're in a bar or in an enclosed stadium, for example, with dense people, that the particles can spread far. And that's really the importance of masking. Not only, we call that source control, it's protecting ourselves, but also others from spread. And particularly as we have moved in to the Omicron variants that have high contagiousness, wearing a good fitting mask is key. So I'll transition from there to talk a little bit about the pandemic. Here, I just wanted to show you an example. This is here someone sneezing, and this is a gas cloud of virus particles. And this is already 7 to 8 meters in distance just from a sneeze. One of the things that is we've seen, and for those of you who've been ill with COVID-19, you can know that the infection not only infects the lungs, but many organs in the body. And that is because the virus attaches to what's called ACE2 receptors, angiotensin converting enzyme 2 receptors. And these receptors, or almost like a docking point for a ship, these receptors are located in different organs across the body. So the nasal passages, the lung, the small bowel intestine, where people can have diarrhea, the heart, we know that there can be involvement of heart inflammation, the eye, the liver, the bladder, the kidney, the brain, the genital tract, across the placenta, which provides a barrier and nourishment to the growing fetus. So we know that this infection is not isolated to the lung. And so if you see on this bar on the right-hand side, there's something that says the ACE2, that's the receptor, the SARS-CoV-2 viral particle is coming to bind at that docking point. And so much of the treatment modalities that we have are aimed at blocking viral replication. That's the early phase, the viral phase, and then the next stage of disease is this inflammatory phase, which is the consequences of viral infection, and that's when the body's immune system becomes like a storm. I'm going to move forward. So where are we with the pandemic? When I came here in December, it was just after Thanksgiving. And so we remember the emergence of the Omicron variants that had spread from South Africa, Botswana, Hong Kong was really a global trajectory of a new variant. And then we saw this massive peak that you can see, that large red peak up into January and February with a rapid rise in cases that then fell down in February and March. And then as we've come into April and May, we've seen this climb in cases. The daily case reports are 4 times as high now as they were in April, but still a fraction of where we were back in January. The most recent uptick came first in the northeast of the US, Puerto Rico has reported new infections at the highest rate in the country. Those case levels have started to level off. And infections and hospitalizations are increasing quickly around much of the South and Southwest. We know recently that we've surpassed more than 1 million total deaths from coronavirus. And you can see here the peaks in deaths where these are the red marks. There's been a 22% increase in deaths in the past 14 days, with about 360 announced each day more recently. One thing I wanted to mention here, often in the news, we hear about Omicron being the variant, a milder disease. But one thing to note, it is very contagious. And so the more people that are infected, the greater risk there is for death. And we've had the largest share of deaths in the Omicron and Delta phase with just the sheer volume of people who were infected, which increase the risk for death. Even though this is seemingly a mild illness, the more people who are exposed, there's a greater risk to mortality. We have used this word called variant, and I wanted to make sure that we all were thinking about it in a similar way. So when a virus copies itself or reproduces, and this happens with other viruses, including HIV, there's often a change in the genetic code or the material, and these are called variants. And these mutations or changes may cause the virus to more easily spread from person to person than for example, in the Omicron variant, there was more transmission contagiousness in the Delta variant and greater ability to resist the effect of the vaccine or the immune system. And I wanted to cite a recent paper in the JAMA by Jeremy Faust et al., a brief report that showed that there was more all-cause excess mortality, and he gave the example in Massachusetts during the first 8 weeks of the Omicron period than during the entire 23-week Delta period. So while we think overall many people do just seemingly fine, we have to look at that with the Omicron variant. That's not exactly the truth. We know that there's a lot of loss from work days, difficulty in being able, just the sheer nuisance of being sick, but also the more people that are ill, the greater their chances for severe disease, particularly in the older population, 65 and up, even when vaccinated, who can have severe consequences. So we want to reduce the chance of anyone getting infected. Right now, the BA.2 variant of Omicron is the most common isolate in the United States. And BA.2 is different from the BA.1 variant that I was talking about when I came back in December because of the increase in mutations, particularly around what's called the spike protein. BA.2 is 1.4 times more contagious than BA.1. The symptoms are very similar to the BA.1 Omicron strain. So sore throat, throat infection, diarrhea, nausea, vomiting, muscle aches, headache, nasal congestion, and fatigue. And as of the end of May, just last week, 58% of the SARS-CoV-2 isolates in the US were BA.2.121. So let's talk now about vaccination. Again, I said, one of the things that we wanted to be committed to in our pandemia is letting you know what we know and areas that we're unsure of, but there are things that we are so clear about the COVID-19 vaccines. These vaccines, and I'd like to say, we've talked about how impressive it was to quickly go from a clinical trial and investigation to getting a product that was available and very effective into our population in the US, and we need to do more work on that, and particularly globally. But this technology was based on decades of scientific work. So it may seem new, but this is actually a well-developed science. COVID-19 vaccines are safe, and they are much safer than getting COVID-19. And the vaccines are effective at preventing severe illness from COVID-19 and limiting the spread of the virus that causes it. The CDC recommends COVID-19 vaccines, including boosters, for everyone ages 5 and older. And hopefully in a couple of months, we'll be coming back and talking about our little ones who are less than 5. In fact, our COVID-19 Prevention Network Vulnerable Expert Panel will be meeting later in June to discuss the Moderna and Pfizer data, which will be reviewed in the coming month in June by the Food and Drug Administration for the kids that are 4 and younger. COVID-19 vaccines available in the US are effective. They're effective at preventing people, especially those who are boosted, from getting seriously ill, being hospitalized, and even dying. And you're best protected from COVID-19 when you stay up to date with the recommendations. So we're going to talk about what being up to date means. You're up to date when you have received all the doses in the primary series. So we're going to talk about what that is, and all the boosters that are recommended for you when it's eligible. A little bit about COVID-19 vaccine effectiveness. So the mRNA COVID-19 vaccines, which are the Pfizer and Moderna products, were highly effective at preventing hospital admissions through the Alpha, Delta, and Omicron waves. I cite here the British Medical Journal paper. 2 doses of an mRNA vaccine, so either the Pfizer or Moderna vaccine, lowered the risk of COVID-19 related hospitalization by 85% during the Alpha variant, 85% during the Delta variant period, which in the US was into the summer of last year into the fall, and 65% during the Omicron period. Now, so I said 2 doses of an mRNA vaccine. What's important to note is that 3 doses of an mRNA vaccine lowered the risk of COVID-19 related hospitalization during the Omicron period by 86%. And that is why it is so important now to get a booster, because when you get the booster, you raise up the effectiveness of the original vaccine series, and we get back up to a really effective area at 86% at reducing serious consequences of infection. But for all of us who are working and trying to make it easier for individuals to get vaccine, we have a lot of work to do, because only 45% of individuals in the US are up to date with the 3rd dose or the first booster. So we have a lot of work to do. We know that we need extra vaccination, particularly in the Omicron period, and that getting this extra dose can help bring the effectiveness of the vaccine way back up in preventing serious illness. It can be hard knowing who needs to get what vaccine. I'd first like to say, lean on and use resources that have been vetted by the scientific community. This is the Centers for Disease Control COVID booster tool. I've put the website at the bottom of the screen. What you do is you go through each of these steps. How old are you? And based on who you're trying to help get the vaccine, it will then ask you the age and the kind of vaccine that you've gotten originally, and it will help determine when you need and whether you need a booster shot. So there are different types of vaccines that are used in the US, and there are 3 COVID-19 vaccines in the US to prevent COVID-19. The Pfizer-BioNTech vaccine is approved for adults and children ages 5 to 17, or the Moderna vaccine for ages 18 and up. Those are the 2 COVID-19 mRNA vaccines, and these are the preferred vaccine options in the US. You may get the J&J or Janssen vaccine in some situations, so we'll talk a little bit about that. Now, the FDA passed in March 29th, 2022, regulatory action recommending the second booster. And so the CDC updated its vaccination guidance based on that some people may receive a second booster dose using an mRNA COVID-19 vaccine at least 4 months after the first booster. Who were those populations that should receive the second booster? Those are individuals age 50 and older, people ages 12 and up who have moderate to severe compromised immune system, and people ages 18 and older who received a J&J or Janssen vaccine as both the primary and the booster dose. So let's go through this a little bit more closely. In addition to who should receive the second booster dose, we know it's individuals with certain underlying medical conditions that increase the risk of COVID-19 illness. If you live with someone who is immunocompromised and at risk for severe disease, or who cannot be vaccinated due to age or their contraindication. You're eligible for a second booster dose if you're at increased risk of exposure to SARS-CoV-2 due to your work. So for example, if you're a healthcare worker or you live in a congregate care setting or a correctional facility or other activities, or you're living or working in an area with medium to high COVID-19. So let's go through each of these examples. And I'd also like to emphasize speaking with your physician or healthcare provider about all of these decisions, particularly if you have questions, and using the CDC COVID-19 vaccine booster tool. So what does it mean to be fully vaccinated with the mRNA vaccine? So what that means is in the primary series, you've received 2 doses of the Pfizer vaccine given 3 to 8 weeks apart, or 2 doses of Moderna vaccine given 4 to 8 weeks apart. That means you're fully vaccinated, and fully vaccinated starts 2 weeks after the final dose in that primary series. So fully vaccinated means in the mRNA case, you've received either of these 2 vaccines, you've received 2 doses of them in this time period apart. What does up to date then mean for COVID-19 vaccines for you? If you received the Pfizer or Moderna primary series, so those 2 vaccines, then you've gotten 1 booster of either Pfizer or Moderna. And for most people, that's going to occur 5 months after the final dose in that primary series. The second booster of either Pfizer or Moderna can occur, I mentioned, for adults ages 50 years and older, at least 4 months for the first booster. So we're recommending that individuals ages 50 and up get that second booster with an mRNA vaccine starting 4 months from the first booster. At that point, you are up to date. So you've gotten your, this is the mRNA series, and it's the second booster. If the initial vaccine was J&J, the Johnson & Johnson or Janssen, the first booster can either be the Pfizer or Moderna for most people, at least 2 months after the primary dose. For people who are moderately or severely immunocompromised, they get a dose at least 2 months after the additional dose of a Pfizer or Moderna vaccine. And then the second booster is either Pfizer or Moderna at least 4 months after the first booster for adults ages 50 years and older, and people who are moderately to severely immunocompromised. So what you'll notice here is that for individuals who started with an mRNA vaccine, either Pfizer or Moderna, they're sticking through most often with the mRNA vaccine. For people who started their first dose with J&J, we then, if there isn't a contraindication, move them to the mRNA, the Pfizer or the Moderna for the booster. There's been some questions Luis was asking me about mixing vaccines, and the CDC does not recommend mixing products for the primary vaccine series. So as we remember, the primary vaccine for the mRNA was those 2 doses. But if you receive the first dose of a Pfizer or Moderna COVID vaccine, you should get the same product for your second shot. So Pfizer and Pfizer for your primary series, or Moderna and Moderna. People ages 18 and older may get a different product for the booster. So for example, if you had 2 Pfizer shots for your primary series, then you can get the booster with Moderna. Children and teens ages 5 through 17 at this time must get Pfizer because for a booster, that's what is approved through the FDA. A little bit about the timing. People who've had COVID should wait to receive the vaccine until they've recovered and completely out of their isolation period. There's some flexibility about when to get the next vaccine dose, and if you're due for either the primary dose or the booster, and the guidance is waiting up to 3 months from when your symptoms started, as reinfection is less likely in the first weeks to months after infection. Now, there were some questions about vaccines that have been administered in other countries. I'm not going to go into detail on this, just to say that the vaccines that are listed for emergency use by the WHO, which the US considers as acceptable, include the Johnson & Johnson, Janssen, Moderna, Pfizer, AstraZeneca. And then you see a number of these that are in implementation outside the US. So what do you do if the COVID-19 vaccine that you received is something different than the three that we have in the US? So the CDC recommends that people who received a COVID-19 vaccine that the FDA has not authorized or approved, or that the World Health Organization does not list for emergency use, start vaccination over. So if you've received a vaccine that was not on the list that I just showed, they recommend starting over with an FDA authorized or approved COVID-19 vaccine. And before receiving an FDA authorized or approved vaccine, waiting at least 28 days after the last dose of the non-approved or authorized vaccine. People outside the US who have not completed the primary series do not have to start the primary series over. They should get one primary series dose of an mRNA. So if you started, for example, Pfizer or Moderna outside the US, and you can get the second dose here, then you would be eligible for your booster based on your group. People who were vaccinated outside the US and who completed the primary series and have not yet received the booster should receive a booster of an mRNA vaccine, so either Pfizer or Moderna, at least 5 months from their last dose of the primary series. So just as if, you know, the usual scheme that I mentioned here. So I'm going to pause now before I transition. You know, I want to say a little bit about the second booster. What were the reasons that the FDA, then the CDC, approved and recommended a second booster? Part of it was the increasing evidence that immunity begins to wane after 4 months. Part of this was the understanding that there were decreased effectiveness of the vaccines in the Omicron variant. So there was the need for boosting, in particular to avoid breakthrough infections. We know about the excess mortality in Delta and Omicron for individuals who are age 65 and over. And there was an Israeli study at the time under peer review that looked at a second booster and showed a 2-fold higher death rate in individuals who had 1 booster versus 2. Particularly in those age 80 and up, the death rate was 10 times and higher than in those that didn't get the second booster. So accumulating evidence of the benefit of getting a second booster, particularly in those who are older. I will transition to say the other area, and I can answer this in the questions, is of course treatment. And I'm an infectious diseases physician. I work in the community setting and with multicultural populations, particularly racial, ethnic, and linguistic minorities. We have a lot of work to do to get COVID-19 treatment out to those who are outpatients, who are moderate to severe risk of severe illness from COVID-19. We can talk about that in the Q&A. We know that just to emphasize, how do we stop COVID-19? Vaccines are a cornerstone in how we prevent infection and reduce the risk of serious consequences. And then going back to basics that have been the case even before coronavirus, which is washing hands with plain soap and water, covering your mouth and nose with a mask when you're around others, particularly when you're in indoor settings and dense crowds, and practicing social distance. And I'll end, but in many ways, the key component is we have a lot of the science to be able to make major advances in turning the tide with COVID-19. But these disparities, as we have seen, racial, ethnic, socioeconomic disparities that preceded COVID-19 continue, not only in vaccination, but also in treatment. We should really use the lessons that we've learned in HIV from how do we help people prevent infection, but also encouraging testing, linking people to care, and getting people to remain healthy, thinking about all of those barriers and all of the strengths that exist in the communities, particularly trusted peers who can communicate in individuals' language and understand the culture and local circumstance are so important in helping all of us get this knowledge into the community. We have still a lot of work to do around improving vaccination in children, as well as the boosters, which we've had lower uptake. We know that there are lots of reasons why people may not be able to get access to care, and the basic things still remain important. People need safe and regular, stable housing. They need access to food, particularly those in our frontline communities. We need to be continuing to provide these kind of wraparound services so that people don't have to choose between taking time off to get a vaccine and their livelihood. And that means bringing a lot of these services into the community, into the food pantries, into the shelters, bringing these services where people are. We need continued attention to outbreaks in schools and making testing available, making sure that our health information is really tailored to the most affected communities, and that we continue to have a really strong attention to mental health and substance use, which were challenges before COVID and have only been accentuated during these periods of stress and isolation. So I will end there and look forward to your questions. Thank you.
Thank you very much, Yuli, for the amazing presentation and update on COVID-19 and the vaccines as well. It's more clear now about the combination of boosters that we are receiving. I received my 4th booster a while ago, so 4 Modernas. So there's some questions here from the audience. I'm gonna see. An anonymous person said, I have heard that some people have received several vaccines a month and not recommend those. What are the consequences? I mean, what are the consequences are if somebody goes and decides to take vaccines over and over, apparently?
You know, one of the ways that we try to keep organized about vaccines is either there's a registry, having a card. For example, in Massachusetts, it gets entered into a registry. So we try to keep track of the vaccination status. There are some people who do need a little bit more vaccination, and those are individuals who are immunocompromised, so who have organ transplantation, who take medicines that reduce their immune system, like, for example, have a rheumatological or autoimmune condition, individuals who have advanced HIV infection, meaning low CD4 count or elevated viral load. Those individuals are going to need an additional dose after their primary series. And so we want to make sure that they're getting, if they're getting Pfizer or Moderna, the 2 doses is insufficient. They need to then get a booster to actually make those 2 initial ones work, because we're not sure that the vaccines will have the same effect. And then we're going to make sure that they have additional dosages through the boosters. And I should say we want to make sure that people who do not have an intact immune system or immunocompromised know that there is what's called pre-exposure prophylaxis called Evusheld, which you can talk to your physician about, and that is to prevent the risk of being infected. Just like we have PrEP for HIV, that this is a kind of injection to help in case the vaccine isn't fully active.
Since you talk about PrEP, I just wanted to ask you a question. It's not related to boosters, but I read a while ago that PrEP, Truvada, tenofovir, people who was taking PrEP received some sort of protection against COVID-19. Is that true?
That's an interesting question that I haven't heard about. We know that some of for example, Paxlovid has protease inhibitor, so it's a similar class as many of the HIV medications. Many of the HIV medications were under evaluation for coronavirus treatment, but I'll have to read about that observation.
All right. So another question is, I've heard that some people have received several vaccines. No, that's the same one. About the people with Johnson & Johnson that have a J&J booster, if they are above 50 years old, they can have another booster. It has to be JJ, or they can change to Moderna or Pfizer.
We recommend that the booster be the Pfizer Moderna, the mRNA vaccine. That's right.
Esther Patterson asks, if you get tested COVID positive, do you still need to booster? And if so, how soon after you are symptomatic?
Yeah, so that was, this is a great area to also talk to if you have a physician, to talk to your physician or healthcare provider. There will be some immunity related to infection, but it is not as good as the combination with vaccination. So, depending on when you were due for your vaccine, it may be somewhere from 2 weeks, meaning like the time that you would come out of isolation. But given that we know that there's probably some immunity related to natural infection, that people can wait around 3 months to then get their booster, for example, if they're due for it. But getting natural infection is not a reason to not get vaccinated. Natural infection, meaning turning positive related to the virus, is not a replacement for vaccination, because the immunity is not, it does not stay, it is not as strong as getting the vaccine.
Another person asked, if I have 2 Modernas and a Pfizer booster, what booster do you recommend, Moderna or Pfizer?
This is an area of, thank you for that question. And the question shows a lot of curiosity. It's something that we're thinking about as physicians. This is an area of a lot of investigation. We don't know exactly the answer. I can tell you that the Pfizer and the Moderna, they're both mRNA vaccines, but they work a little bit differently. So it's reasonable to say that after you've finished your primary series, meaning those 2 initial doses, just say you have 2 of Pfizer or 2 of Moderna, it's reasonable to get a booster with a different kind of mRNA vaccine because they work a little bit differently. But there is no decision or hard and fast guidelines from the CDC yet about how to do that.
Another person asked, do you believe a second booster will be coming for those 15 to 50 years of age?
Yeah, I think, in part, it's going to be following the evidence and also the availability of vaccine. We know that protection does wane over time. And the area that we know that you do need protection regardless of your age is if you're at high risk for exposure. So meaning that you're a healthcare provider, you may be under 50, but you're at risk of your frontline worker, or you may be working in a congregate care setting, like a nursing home, a long-term care facility where you're younger, but your risk of being exposed is higher. And so there you will get the second boosters. We'll see. I imagine we anticipate that maybe in the fall there will be more specific vaccines that are tailored to different variants. And so we just have to be flexible and open-minded as we're learning from more of the evidence.
there are people who are doing it for incentives. I've heard people doing it for incentives. This is a comment, I guess. They're saying that there are people that just getting vaccinated for the incentive, the money that they are receiving, not because they're interested in getting vaccinated. So another person says, I'm a long hauler, March 2020. I got my booster in November 2020. My symptoms got worse. Should I get the next booster that has come out? I'm 70 years old.
Yes, so this is someone who, you said November of 2020?
November 2020.
2020. Yeah. So if it's November 2020, then we're over a year from vaccination. And if you're 70, you would be due for the second booster at least. So we do know, we're learning a lot about the long-term effects of COVID and inflammation. And there is some association between vaccination and reducing the risk of long COVID. So yes, I would recommend that this person who is 70 years old get a booster, because we want to prevent the risk of severe illness. And what has already been learned is even if you get infected with one strain of Omicron, you can still be at risk. So if you got infected with BA1, you can still get infected with BA2. So there is some cross immunity, but it is not great. So we do want to recommend vaccination even if you've been infected.
Maria, how can you know that you are completely recovered from infection of COVID-19 if you still have extreme tiredness and joint soreness?
Well, I guess it depends how we define recovered. You know, there's the contagiousness part, which for people who are healthy individuals, you know, if you do not have immunocompromised states, can come out of isolation in 10 days. But people who have an immunocompromising condition may continue to shed virus for a little bit longer. And then there's maybe what, remind me her name again, who asked this question?
It is Maria Silva Dorantes.
Maria. So then there's a question of the symptoms that we might have. And those may, depending on the person, may last longer than the actual virus that can be spread to someone. So I think that, you know, it really depends on the person. There is a large study by the NIH, the Recover Study, which is looking into the effects of long-term effects of COVID or post-acute COVID sequelae. And I would encourage people who can enter those trials to join those studies so that we can learn much more about the long-term effects of COVID, and hopefully they can also benefit from multidisciplinary care, meaning rehab medicine, pulmonary physicians, mental health and psychiatric support, neurologists.
Isabella Guerra says the length of protection of second booster is not clear, but some data show that it's about 2 months. Should people who qualify for a second booster delay this to coincide with optimal timing, for example, travel or the event of fall and cold weather?
This is such a good question, right? Because I think this is a great example of a conversation to have with your trusted healthcare provider, because you can talk about not only what your risks are, but also how comfortable you feel with risk. And so all of those factors are going to influence whether you should or can wait. You know, for example, if you were an individual with a lower risk and you were in an environment with lower COVID transmission, you might want to wait until the fall when we suspect case counts will come back up. But if you're an individual who's at higher risk now, particularly if you're in an environment with moderate to high transmission, or you're going to be anticipating being in an exposure, you would want to be vaccinated earlier. So this gets into really the personal decision of the timing.
So we have a lot more information than we do. How do you foresee the future? Do you think we're going to get vaccinated every year? you think, how are we going to handle the endemic now that's coming, pandemic?
Yeah, I have been hesitant about making too many predictions because things seem to change. We do know, for example, with flu, we get vaccinated every year. We do see that there is some waning in immunity, even with the initial vaccines for COVID. So I would anticipate there would be repetition or recurrence of vaccinations, but I think we also have to see what's required in terms of changing vaccines. Do we need different vaccines for different variants, or vaccines that are able to respond more broadly to different subtypes? So I think we'll get more evidence and come back and talk about that.
So we have the Alpha, the Beta, the Delta, the Omicron coming up. Is it possible that more strains, different strains come up, and then we have to do more vaccines for something different?
Well, I think that it's a natural part of evolution for viruses to mutate like this. And the more virus that is present, the more risks there is for mutation. Just like in HIV, when there's a high viral load, there's a risk of development of mutations from viral replication. So one of the reasons that we really want to emphasize vaccination is to reduce the community viral load, reduce just the same sort of words that we use in HIV, to reduce the chance of spread of resistance. And it really underscores how important our global community is. Viruses don't see a wall, they don't see a country border. People, we move in and out, and we're really a global community. And so it just underscores how we really need to emphasize getting vaccination into all of our communities, not only in the US, but also abroad.
The person who asked about the 7-year-old guy, he corrected. He said the booster was November 2021. So he should, if I think he should get it, if that begin after November 23rd, I don't understand what he says. But I think he wants to know if you got vaccinated or not. But.
Yeah, if you had your first booster in November 2021, then you would be eligible for an mRNA vaccine about four to 5 months, or no earlier than 4 months. So at this point, May 31st, you would be eligible for your second booster if you're 70 years old.
One more question from Mercedes Chavez says, how safe are the boosters for people with history of Bell palsy and trigeminal neuralgia?
Those aren't contraindications for receiving boosters. I'm not sure if this individual was talking about having developed that from prior vaccination, but these vaccines are very safe. I would also recommend for people who have specific questions to look on the CDC website. There is a vaccine adverse effects monitoring system. So if someone does have a side effect, because those can occur rarely, that they can be monitored and cataloged. The COVID-19 Prevention Network also has some wonderful materials in different languages on vaccines. For those on the call who want more educational materials, Luis and I can work to make sure that you have those available too, specifically about the questions around side effects.
I think there's no more questions from the participants here. I'm looking. No. So I guess we are going to close now. We are a little bit earlier, like 5 minutes earlier.
Could I say, Luis, something about treatment? I mean, I just want to say, because you know, I work in a community. I'm in Boston and Massachusetts. We're in you know, an urban environment, and theoretically we have a lot of access to Paxlovid, for example, which is one of the treatment options. And the US has a lot of access right now to treatment. And we do know, based on the numbers, that individuals who are eligible for treatment as an outpatient are not getting treatment. And part of that may be because there are providers, physicians that are not familiar with some of these medications, particularly those who haven't, you know, done HIV work and are not familiar with ritonavir. But part of it is also educating the population partly, in ways that are accessible. In my community in Chelsea, particularly in Spanish, making sure that we're using language that is understandable, but also really making sure that the treatment discussions are shared with individuals like community organizations that know the population well. We have one organization, for example, that has a food pantry, and in one day they serve 1,500 people. Wouldn't it be wonderful if there's a mobile van that can come at the time of the food pantry, so that if someone tests positive for COVID, they can also be screened for eligibility for Paxlovid. So I know that there are a number of people on the call who've worked in the area of HIV work. We know that there are lots of barriers, but we try to break those barriers down and bring care to where people are. And I think the more we can bring those lessons learned from HIV to COVID, we can really work to bring treatment. Paxlovid was very successful in reducing hospitalization for individuals who are unvaccinated. And so based on that evidence, if you're within 5 days of the onset of symptoms or test, you're eligible to get this treatment, which is 5 days of pills to reduce the risk of being hospitalized. And there are other options too for treatment. So I mentioned that for people to ask their physicians or healthcare providers, if you do have COVID, to ask whether you're eligible for treatment to prevent being hospitalized.
Is this treatment indicated for people who are vaccinated as well, or just for people not vaccinated?
If you're vaccinated, but if you're at risk, moderate to severe risk of hospitalization or death, meaning obesity, an underlying heart problem, lung problem, cancer, you would be eligible, or age, you would be eligible for treatment, even if you're an outpatient, because we want to prevent someone being hospitalized, getting a breathing tube, and dying.
But the best way to prevent is vaccinated, right?
Exactly.
Yes. So everybody should get vaccine and boosters. Any other questions from the audience? You can write it down. No? Apparently no. So thank you very much, Julie, for being with us again. Amazing presentation, a lot of information that I'm sure all of our participants will and also communicate with their peers. So thank you very much, everybody, for being with us. See you on Pandemia 14.
Wonderful. Gracias.
Okay.